Hello, everyone. Good afternoon. Welcome to Prime Therapeutics Medical Pharmacy Trend Report. We have been doing this for many years, and we're excited to bring you a lot of new trends that are happening in the medical pharmacy space as well as the specialty drug space. I am Kristen Reimers. I'm a clinical pharmacist with Prime Therapeutics. And with me, I have three of my esteemed colleagues. And I'm sorry, let's see, we need to change the slide there. I have three of my esteemed colleagues with me today. Lisa Polakowski, who is the Medical Pharmacy Trend Report Director and lead author of our Trend Report. I also have Laura Walters with us, who is Specialty Clinical Solutions Director, and Ben Messerly, who is Manager of Actuarial Services. And these three individuals are really the coordinators of all things Medical Pharmacy Trend Report. However, it does take a team of individuals. We have over 30 people who work on the overall trend report, analysts and clinical pharmacists, taking in clinical expertise from physicians and clinicians across our organization, as well as strategists and those who have expertise in the pipeline and forecasting, as well as board-certified oncology pharmacists, since oncology is one of the largest trends that we have within this overall trend report. So it does take a team of individuals to make all of this happen, and we're happy to bring this to you today. So starting off and talking about the trend report, wanted to share that you can use this QR code that you see on the screen here to talk about all things medical pharmacy. So this brings you to the page of the actual trend report itself, any history behind it, any of the recent postings from the trend report and some of the high-level details from all of that. You can find all of that on this QR page. So in a brief overview, the trend report has been produced for 15 years. So this is our 15th edition of the Medical Pharmacy Trend Report, and we're happy to bring that to you today. We have a lot of interesting things that have evolved since that first report that came out back in 2009. And it has always included payer data that we analyze and look at. We slice and dice in a variety of different ways to look at the overall trends and the spends and come up with some of the answers as to why some of those trends might be occurring. And then we couple that with payer survey data, where we're asking health plans across the country, national and regional health plans, about their opinions in terms of what's happening in this space and how they're managing drugs on the medical benefit. And we bring that together to come up with the overall trends that you're seeing in the report itself, as well as creating new reports that we have within the trend report this year as well. So our report spans both the commercial, Medicare Advantage, and Medicaid line of business. We looked at all of the claims data from 2024 calendar year. We do have to allow for a 3-month period of claims run out for those claims. So there is a little bit of a delay in analyzing that overall data, but that is included in as a part of this. The claims run out, and we looked at over 1,100 different HCPCS codes within the report. Additionally, new this year, what we've included is integrated data, where we've looked at plans that have data across both the pharmacy and medical benefit and looked at some of the most unique categories that might be most influential. So we looked at the area of oncology, obviously the highest trend in spend. We also looked at multiple sclerosis, where there's multiple products across both pharmacy and medical. And then we looked at the immune globulin category as well to take a look at what could be influencing things across both the pharmacy and medical benefit and take a more holistic look at the overall therapeutic category. So what we have in store for you today is we're going to take a very broad look at some of the historical perspectives from 15 years ago and then 5 years ago, and then start to really dive into the year-over-year trends, what's happened in 2024, look at what might be causing some of those changes and what's driving that, as well as get into some of that deep dive on the integrated categories. And then we will have time at the end for questions. So you will see the Q&A button on your screen. Please type in questions at any point if you think of them during this talk, and we will leave time for that at the end. All right, so moving into what happened in 2024, there were 61 FDA drug approvals for novel new therapies. And these are therapies with a new active ingredient. This doesn't include drugs that are the same active ingredient. It does not include biosimilars. This 61 new drug approvals was down by about 10 from the previous year in 2023, where we saw 21 drug approvals. The breakdown of this 61 therapies was 16 of those were traditional therapies, and about 74% or 45 of the overall approvals were specialty drugs. Those can be broken down to 23 on the medical benefit and about 15 specialty drugs on the pharmacy benefit, with 6 products being on both benefits. There is one product, it's Letibo, which is a botulinum toxin, which is for cosmetic use. It actually is not classified under pharmacy or medical use because it is cosmetic and typically not covered under most benefits. So that was the breakdown in that, and that's how it gets you to the 61 total. Additionally, there are blockbuster therapies. There are a total of 19 blockbuster therapies, and these are therapies that were expected to peak gross annual sales predictions by $1 billion, or higher. We've listed on the slide for you here 7 of the medical pharmacy therapies, and they span a variety of different therapies for oncology, the Amtagvi and the Anktiva for melanoma and bladder cancer. There's a few vaccines, the Capvaxive, the pneumococcal vaccine, as well as the Mresvia, which is an RSV vaccine for prophylaxis in adults over the age of 60, as well as adults who may be at high risk of developing RSV. There's Kisunla, which is for Alzheimer's disease, and Ohtuvayre, which is for COPD. So a variety of different products that are considered a blockbuster that got approved and are quite interesting. There were 4 gene therapies that were approved in 2024, and Becviz is a very interesting product because it not only was approved in 2024, but it also was discontinued in 2024 because of lack of use for hemophilia B. Kebilidi is a drug for a rare disease. It's AADC, which is aromatic amino acid decarboxylase deficiency in the pediatric population. And then also Lenmeldi was approved for metachromatic leukodystrophy. And then there is also Tecelra, which is a T-cell therapy for synovial sarcoma, which was approved. So those will be influencing some of the oncology markets. So all of these products will be influencing some of the trends, and that's why I'm going through some of these. We also had 11 accelerated approval products that were approved, and 7 of these were medical drugs. 3 of the products that were not mentioned yet is Bizengri, which is a bispecific antibody therapy for oncology for pancreatic adenocarcinoma and also non-small cell lung cancer, Imdeltra for small cell lung cancer, and then Ziihera for biliary tract cancers. Over on the right-hand side in yellow, you can see the biosimilar products that were approved. There were 18 biosimilars approved for 8 different reference products. We highlighted a few here, some of the biosimilars for the reference products of Eylea, Stelara, Solaris, and Xgeva Prolia, which also will see some impacts in some of the trends on that. So diving into some of the overall trends, and my slide is not changing here. Oops, we went a little too far. Sorry for that. So looking at the trends over the last 15 years, we can see some of the impacts. And it's really quite staggering when you look at some of these numbers that the PMPM trend increased by 191% over the last 15 years. And we did a little historical perspective over on the right-hand side of the slide, where in 2009, the costliest therapy that came to market was Solaris, and that was at $410,000 annually for that product. That has slowly increased over time to $814,000 today. However, the really impactful thing is when you look at Lemeldi that got approved last year, that product, the overall cost of that is $4.25 million. It does offer a gene therapy for a very rare disease state, which can be devastating for overall infants, but the cost profile is what's causing that over almost 200% increase. So some of those things are what you can see that really drive the overall trend in the last 15 years. And obviously understanding these types of impacts over that 15-year period of time just emphasizes the importance of using this type of data to inform some of the strategies and management approaches so that members are receiving the drugs that they need when they need them, and they're getting the quality of care that they need, but also making smart decisions in terms of how these drugs are overall managed for the health plan and understanding the spend and the overall trend. So then in looking at some of the data for the last 5 years, when we take a look at that, you can see double-digit trends across both commercial and Medicare Advantage in the overall medical pharmacy PMPM trend, as well as in oncology, which is one of the biggest drivers. What's really impacted that is the utilization and the cost of Keytruda, the oncology immunotherapy. It's grown in triple digits by 153% in the commercial population, and that's due to its 40 different indications across 18 different cancer types. So that has been a trend driver over the past few years since it has been approved because of the overall utilization of that product. And it is making a difference in a lot of different cancer types. We also know that just recently, last month, that the subcutaneous formulation of Keytruda was approved. And it'll be interesting to see what types of impacts that may have on the overall trend. However, I can speak to the fact that we've seen that Opdivo and Tecentriq have already had their subcutaneous formulations approved for some time, and there hasn't been a lot of uptick of those formulations. It still is health plan professional administered, but it is a subcutaneous formulation. It will be interesting to see, however, in the next few years, in 2028, Keytruda should be losing its exclusivity, and there may be a biosimilar available for Keytruda. So hopefully that will provide some relief in some of the overall costs of that product. So these advances in oncology are really helping to treat members that need targeted therapies and really make a difference in their overall lives in treating oncology. But with that, obviously the utilization and the cost of those products make a big difference. So at this point, I'd like to turn it over to Ben and Lisa and Laura. And Ben, I'd really be interested if you could share what's driving some of the year-over-the-year trends in 2024.
Yeah, thanks, Kristen. Yeah, I can kick us off looking at the 2024 data. So this slide shows the 2024 trend for each line of business. The table on the left demonstrates how utilization and cost components affected the overall trend. The total spend here is the allowed PMPM dollars, and the trend is the year-over-year change. You can see Medicaid has the largest trend in 2024, taking over from Medicare, which had the highest trend in 2023. And here you can see Medicare and commercial had decreases in utilization. However, cost increases led to positive overall trends in those lines of business. And the trend contributors were balanced between both cost and utilization for Medicaid. So that's kind of the overall numbers piece. Lisa, what do we see from a clinical perspective behind these numbers?
Yeah, Ben, thanks. So regarding the utilization, we saw less utilization across all lines of business for low-cost therapies, and we're defining that as less than $100 in annual cost. These low-cost therapies include classes such as corticosteroids, infectious disease, and testosterone. Across all lines of business, our PMPM trend was driven by oncology, as it generally is every year. And then if we look into some of the other lines of business, so in commercial and Medicaid, we had vaccines actually driving utilization trends. So we saw, Kristen mentioned before, some of the RSV vaccines that got improved. We also saw utilization in pneumonia, flu, and COVID vaccines. And then when we look at Medicare, we see Vabysmo driving spend in Medicare, and we'll have some additional data on the ophthalmics later on in the presentation. So if we go over to the next slide, we'll look at our top spend drugs impact on trend. And we see that Keytruda is the number one drug in every line of business by spend. It still has double-digit trend, although our growth has slowed. And one of the some of the big stories that we see in the top drugs, we actually don't see it on the chart because of changes in trends in the past year. So when we look at Medicare, for example, our top three drugs, Keytruda, Opdivo, Darzalex Faspro. However, what we don't see is that Eylea fell out of the top three drugs by spend. It was in there in 2023, and this is due to decreased utilization of Eylea because we both had Eylea HD entering the market, and we saw the increased uptake of Vabysmo. And like I said, we'll touch on ophthalmics later on in the presentation. When we look at Medicaid, again, we see Keytruda, Ocrevus, and Opdivo in the top three this year. The one that fell out of the top three was Entyvio. That PMPM actually decreased by just over 19% in 2024, so it's no longer a top three drug. And we think that this is actually due to some shifts to the subcutaneous form of Entyvio. We had Entyvio IV, was what I was referring to previously. So it could be shifting to Entyvio subcutaneous or even Skyrizi. And we actually saw spend in the Crohn's and ulcerative colitis therapeutic category decreased by that same 19%. So it's just an overall category decrease. So we see Opdivo entering the top three drugs by spend due to increased utilization. And we think this is wise because between October 2023 and October 2024, Opdivo received expanded approvals in melanoma, urothelial carcinoma, and non-small cell lung cancer. And that's our story with our top spend. So Laura's been patiently sitting on the sidelines for this webinar so far, so let's get her thoughts on the top therapeutic categories.
Thanks, Lisa. Hate to sound like a broken record here, but no real surprises as oncology continues to drive spend in all of our lines of business with a spend of more than 5 times the number 2 category. An interesting thing to note is that Medicaid oncology had the largest increase compared to commercial and Medicare. A large contributor for this was Rylaze, which is a drug for leukemia and costs well over $700,000 annually. It experienced a 55% increase in utilization that led to a 140% increase in PMPM spend. Other high-cost therapies that also saw increased utilization were the CAR T cell therapy Tecartus and the radiopharmaceutical agent Pluvicto. Medicaid also had the largest therapy driver of all the lines of business, an enzyme replacement therapy. This was driven by increased utilization of Elaprase and Vimizim, which treat genetic liposomal storage disorders, mainly affecting children. Ben, do you have something that you can share with us a little bit on the data on this, please?
Yeah, a quick note on the Medicaid data in particular. This line of business is different than commercial or Medicare in terms of volatility. The membership is less consistent month over month and year over year. The mix of states included plays a big factor, and the mix of drugs can vary quite a bit depending on the population mix currently covered. So it's not surprising that we see, in terms of a percentage increase, we see a lot more volatility on the Medicaid side.
Great call out. Thank you.
And we can see that kind of play out a little bit more on the long range forecast, which we'll look at next here. Here's the 5-year historical or the 4-year historical view plus the 3 years of forecast. In 2021 and 2022, we see the COVID impacts on utilization and then the subsequent bounce back that ripples through the year over year trends. In 2023, we saw a lot of one-time impacts on utilization early in the year that leveled out towards the end of 2023 and into 2024. In particular, expanded indications and new therapies introduced drove that, and that was kind of a one-time increase in utilization. And that moderation continues into 2024, and we anticipate the baseline trends to increase in 2025 for commercial and Medicare. But as mentioned before, the Medicaid population in particular has a lot of inherent variability and could also see a higher trend in 2025. This is kind of our best estimate of that. I will speak to the forecast methodology when we talk about the rare disease categories. Our forecast team does a great job pulling all that together. And throughout the trend report, the therapy level analyses dig into the effects of both new market entrants as well as potential offsets to existing therapies in the same category. And it really helps understand kind of the changing dynamics there. But in terms of pipeline drugs, Lisa, could you speak to some of those?
Yeah, so some highlights from the pipeline that we include in the forecast this time. Datroway, which was approved earlier this year to treats breast cancer and non-small cell lung cancer. Also, we saw Imavi for myasthenia gravis approved this spring, and that's for patients with AChR or MuSK antibody positive myasthenia gravis. And additionally, Amvuttra received an expanded indication for hereditary transthyretin amyloid cardiomyopathy. And as Ben mentioned, rare disease drugs play a role, and we'll touch on those later on in our rare disease section. But overall, we are anticipating a more stable year-over-year trend now that the COVID volatility seems to be leveling out. So we'll dive into our oncology trends. This is our number one category by spend. And one of the things we'll be doing is weaving insights from our payer survey in throughout the next few topics. So let's dive in. And we've got quite a lot to unpack on this slide. So first, looking at the chart on the left, we see the interplay between utilization, which is based on claims volume, and cost, defined as allowed per claim. So the full PMPM trend is the number on top of the bars with the arrow. And then Ben, I'm sure we have some viewers wondering why the percentages on the bar graph don't add up to the full trend. So can you give a quick explanation why this is?
Yeah, so the percentages here for each line of business are multiplicative. They're not additive because the components compound on each other. So if you multiply the percentages together, that's where you get the total.
Okay, great. Thanks for that explanation. So 2 items to jump out right away to me when I look at this chart. First, we see a utilization decrease in commercial. This decrease in claims was also accompanied by a similar decrease in utilizers overall. And for oncology specifically in commercial, we saw decreases in spend for neuroendocrine, male reproductive, respiratory, and skin cancers. In terms of cost, we have the cost raising for oncology. It was Jemperli for endometrial cancer and Rylaze for leukemia and lymphoma that were our top contributors to cost increases. Secondly, we see that Medicaid trend is being driven by an increase in our utilization, which again was accompanied by a similar increase in utilizers in Medicaid. And then for types of cancer for this line of business, we saw the largest increases in male reproductive cancers, GI, leukemia, and multiple myeloma. Looking at our trend graph on the right, one note is that we see overall oncology spend for Medicare is over double that of commercial. Oncology accounts for 55% of total medical pharmacy spend in Medicare, and I'll say only, with some air quotes, 40% of total medical pharmacy spend in commercial. Our top Medicare cancer types are respiratory cancer, multiple myeloma, and urinary system cancer, with our biggest increases in 2024 being the reproductive cancer category. So I think this will be a nice segue into our next slide covering payer survey. So Laura, looking at this next slide, what are payers saying about oncology?
Yeah, so as you pointed out, with oncology spend continuously on the rise, our payers are looking into various strategies to bend the spike. So we asked several questions on the survey about their approaches. So a few of them are highlighted here. I wanted to call out that the first biosimilar approved in the US was Xeroxio in 2015, which is an oncology support agent and biosimilar to Neupogen. Since that time, there have been 74 additional biosimilars approved. 45% of those are oncology agents. So we asked payers how they are strategically using the biosimilars, and the majority of them reported using step and preferencing strategies. Also of note, which we called out earlier in the webcast, FDA has approved several subcutaneous forms, and some of them use oncology or for oncology agents. And the benefit of these is convenient delivery and potentially lowering overall cost. So we asked payers about their concerns with these new formulations. And not a surprise, cost was by far the number one concern. While sub-Q products were released for Opdivo, Tecentriq, and Keytruda are at parity in pricing with the IV formulation, the cost concern is likely alleviated only temporarily until the biosims for the IV that Kristen mentioned earlier hit the market later this decade. Next, we asked about how payers are using regimen-based reviews. And the reason we asked this is the AMA released a consensus statement along with other organizations on improving the PA process. In the statement, there was a call for automation and efficiency. The regimen-based reviews allow providers to submit one request for multiple drugs being used in a treatment of a single disease versus multiple requests. And in our survey, 52% of the respondents already had or were implementing the regimen-based reviews at the time of the survey.
Yeah, and Laura, I'll just add that I think, based on what you said, that there's a lot of different strategies that can be deployed. And going back to your biosimilar comment, it has made a big difference. We've seen tremendous uptake of the oncology biosimilars for bevacizumab, trastuzumab, and rituximab, and that's really making a difference in some of the overall costs to members and helping to improve access as well. So, deploying those types of strategies that you mentioned here and just getting the payers' perspectives on some of that helps to put that, into perspective and understand what's happening within the market. But also, although there's a lot of new products that are being approved and that are very high cost, the biosimilars have really helped to decrease some of the costs on the reference products.
Absolutely. So moving on to our next slide, another hot topic for many is accelerated approvals, also mentioned earlier by Kristen. This is especially applicable in the oncology section because the ongoing accelerated approval trials, 69% of them are for an oncology indication. Rare disease vaccines and infectious disease are among other top therapies that currently have accelerated approvals. Our survey revealed some varying strategies with accelerated approval drugs. The recommendation is to use effective management strategies in creating access criteria through prior authorizations, or case management, for instance. Also, health plans are weighing the risks of benefits of managing these drugs, along with some predictive financial models that may determine if coverage is even warranted. So I think that wraps up oncology. Lisa, if you'd like to take over on the next section.
I can jump in and introduce this one. So new in this year's report, we developed and incorporated a new cross-benefit analysis with membership distinct from the rest of the report. So this includes membership with claims data provided across both medical and pharmacy benefit types. This integrated view, which consists of claims data from 2023 and 2024, allows the reader to observe drug trends in a holistic manner. And though medical and RX claims come in different formats with different billing characteristics, we're able to aggregate both together into one combined view for certain categories, and we plan to expand the list of included categories in future reports. The first category we'll look at is oncology. Lisa?
Yeah, absolutely. Can't get by without showing oncology some more. So this time we'll look at it through the integrated lens. So a couple things to note here. So the combined spend between medical and pharmacy, it was split 60-40, skewing to the medical benefit side. And that was mirrored in the distribution of the top 10 drugs by spend, where we have 6 medical drugs, 4 pharmacy drugs. And once again, Keytruda is our top spend drug. So as we look at these top 10 drugs, a theme of breast cancer therapy emerges. So 5 of the top 10 drugs have indications to treat breast cancer. We do see breast cancer type a little more in commercial as opposed to Medicare, just because the median age for breast cancer diagnosis is below Medicare age. So we see it more in commercial. So on the pharmacy benefit side, we see our oral CDK4/6 inhibitors. We have Verzenio at number 3 and Ibrance at number 10. And then not shown on the chart, we have the third CDK4/6 inhibitor, Kisqali, just outside our top 10. So these are important. A couple indications for these. They're indicated in both early and advanced breast cancer. And our oncology experts note that Ibrance in Q4 of 2024 received an expanded indication in combination with Idovebi and fulvestrant. So they note that that may actually shift utilization as we go into 2025. One other factor with Ibrance is that loss of exclusivity is expected in 2027, which could further change our spending patterns. On the medical pharmacy side, Keytruda has an indication for breast cancer, and then other breast cancer top spend drugs include Enhertu and Perjeta. And of note, in Q2 of 2024, Enhertu gained an expanded indication with an accelerated approval for adult patients with HER2-positive IHC3+ solid tumors as well. So when we look at commercial, our theme is breast cancer. So let's take a look at our Medicare oncology and see how that differs once we look at that line of business.
And we see. I just wanted to add on the breast cancer. Obviously, it'll be exciting to see what happens over the next year with all of the antibody drug conjugates being studied to be used earlier in therapy. It's really an exciting time in breast cancer. There's a lot of new therapies and different ways for diagnosis. Diagnosis is coming earlier with AI-assisted mammography and those types of things. So I do think that'll be impacting the trend in next year's report. I think we'll see an uptick in some of those agents. Some of them are even being studied to be used earlier in therapy ahead of the CAR T therapies or instead of. So the clinical trials look very promising on some of that right now.
Yeah, awesome. That is an excellent point, Kristen. And definitely with AI assisted mammography readings, I know there's been some great studies about that showing how accurate the AI can be in examining those early changes in breast cancer. So it's a great point to point out. So thank you. So we'll switch over here now to Medicare for integrated oncology. And we see for this line of business a little different. So only 3 of our top 10 drugs are medical benefit, whereas 54% of the spend was on the medical side. And then if we look at what these indications are for, in Medicare here, our story shifts to blood cancers. So there's 4 of our top 10 drugs, which are Darzalex, Pomalyst, and then Revlimid and its generic lenalidomide, that are indicated for multiple myeloma. Also, we have Brukinsa, Imbruvica, and Sprycel that are indicated for leukemia and lymphoma, so also considered blood cancers. And these cancers are typically diagnosed in older adults, so we see them in our Medicare population. And then one thing we see here with these blood cancers is just that, we've got a lot of the drugs. Interesting to note that Revlimid and lenalidomide, brand and generic, both show up in the Medicare data. So I want to make sure we continue to move along in our presentation. So let's transition away from oncology and look at some of the other integrated categories. So Laura, what's going on in multiple sclerosis?
Yeah, thanks, Lisa. Glad to talk about something a little bit different here. So multiple sclerosis is a very interesting cross-benefit view due to the high spend on the medical benefit and a good mix of therapies between the two benefits. Within the pharmacy benefit, there are many brand generic, oral, and self-injectable medications. And a few things to point out are that the total spend for MS was practically equal across benefits. However, Ocrevus, Tysabri, and Briumvi spend was 100% on the medical benefit. Now, commercial saw a greater utilization of the newer therapies, and MS remained in the top 10. Although not shown on the graph, there was a shift from the branded oral products like Aubagio and Gilenya to their respective generics. This contributed to a 2.7% decrease in overall category spend for commercial in 2024. Meanwhile, Medicare experienced utilization of older agents like teriflunomide, and commercial saw a shift also from branded oral medications to generic, contributing to the drop in MS spend. Next, we'll take a look at a very interesting integrated category, the immune globulin. Now, I know probably a lot of you are like, oh, immune globulin, it's been around forever. What's the new story? It's still pretty interesting because if you look at this, especially for Medicare, there are both subcutaneous and IV products in claims for both medical and pharmacy benefit. And Medicare is unique in the fact that the benefit billed, whether it's Part D or Part B, depends on the place of the administration of the drug and the diagnosis. This data set, for the first time in our integrated views, shows products with significant spend on both pharmacy and medical benefits, with the spend skewed just slightly towards the pharmacy benefit. So I think we can move on now to rare disease.
Yep, and I just want to make it very, very clear. So now at this point in our presentation, we are shifting back to our medical pharmacy only view. So no more prescription pharmacy benefit drugs. This is back to purely medical pharmacy as we discuss rare disease. And I know we've been promising you guys throughout the webcast here that we were going to get to rare disease. So Ben, I know you mentioned you had some notes on the forecast methodology. So why don't we get to that before we start looking at this category?
Yeah, for sure. Yeah, a quick note on the forecasting methodology. So there's 2 components to consider. There's the pipeline of new drugs, as well as the changes to existing therapies within each category. And we use a time series methodology to forecast that. And when we start looking at pipeline drugs, our models take a best fit approach with within a confidence interval. Here you see our best estimate, but a wide range of outcomes are possible due to uncertainty around potential approval timing, the uptake of high-cost pipeline drugs. And so depending on the timing of that, there can be a wider range of how that impacts and when the spikes are anticipated for when those pipeline drugs come onto the market. So here in the rare disease category in particular, we anticipate high spend for Medicaid for deramiocel, vutrisiran and Elevidys. And so that's what's contributing to the large amount of spend there. And across lines of business, the emerging 2025 data, so data that's not included in this report, but claims that we're starting to see come in, it's not trending as high as expected at the time of publication due to various approval delays. I'm not an expert on those, but Lisa, could you elaborate on those for us?
Yeah, for sure. So a couple different things are going on in the rare disease space. So first, with a drug that is already approved, Elevidys, this is a major factor in this space. It has a $3.2 million price tag. So any member that would have an Elevidys claim is going to be an impact to a plan. However, since our data was run for publication in the early summer, there has been some movement within the Elevidys space. And in July, there were shipments to the non-ambulatory patient population. Those shipments were halted because safety concerns were raised. So we don't anticipate as much effect from Elevidys just because of that non-ambulatory patient population. As of this time of the webinar, are not they're not shipping to those particular patients. Also in the DMD space, Ben mentioned deramiocel. That is a drug for DMD cardiomyopathy that is anticipated to make an impact. Current treatment for the cardiomyopathy of DMD focuses on symptom management. So this would be another expensive off-the-shelf cell therapy to treat the heart failure due to cardiomyopathy, which is the leading cause of death in Duchenne's. The PDUFA date for this drug was in August, but approval was delayed as more clinical data has been requested. For this, the HOPE-3 trial is ongoing, and they anticipate to reapply within the next few months. One other drug that's included in the forecast that it has not been approved as we had anticipated is apitegromab. This is for spinal muscular atrophy. That received a complete response letter in September due to some manufacturing issues. So overall, rare disease can be greatly impacted by very small numbers of patients receiving drugs with these high price tags. And as Ben noted, we attempt to incorporate the possibility of utilization of these very high cost drugs within our analysis, but it is dependent on FDA approval and uptake of the drugs. So we know gene therapies are an area of concern for our payers. Laura, do we have any quick thoughts on the payer survey for gene therapy?
Yeah, just a couple quick things as I want to keep us into some of our more meat of our presentation. But, while gene therapy is relatively new, I think most are aware that the price is very high, and this is raising concerns about its affordability for payers and its availability to the patient. As Kristen mentioned at the beginning of the webinar, the most expensive drug in the US is Lenmeldy, which is a leukodystrophy gene therapy priced at $4.25 million. It's no wonder the survey results overwhelmingly showed financial challenges and concerns at the top of mind. So I think next we're ready to dive into the ophthalmic area.
As promised, ophthalmic injections. So we want to allow time for some questions. So we'll get through this here with just our key points. So looking at our ophthalmic injections graph here, what we see is just that the spend is far more prevalent in Medicare, as you can see from the graph. This is because ophthalmic conditions like diabetic retinopathy and macular degeneration are more prevalent in the Medicare age populations. We see spend is projected to rise in line with more adults reaching Medicare age. Items expected to affect this category in the coming years include Eylea biosimilars and even the potential for some commercially available Avastin biosimilars. So on the next slide here, we'll dive deeper into some of the drugs in this category. And then this is a slide that we used in last year's webinar if you attended. So we've already mentioned for Medicare that Eylea fell out of the top 3 drugs by spend in 2024. So looking at this market share slide, which is based on unique utilizers, can you, Ben, explain the dynamic of this data for these products?
For sure. Yeah, the slide includes treatments for wet AMD and diabetic macular edema. As a result, most of the spend in this category falls within Medicare. In terms of market share, Avastin held steady with 50% of the market. Vabysmo saw market share increase with similarly market share decreasing. This resulted in an overall slight decrease in PMPM trend across the category. Syfovre also saw a market share increase, but treats a different ophthalmic condition, so that's not included in this slide. For commercial, Vabysmo, Eylea HD, and similarly picked up market share, while Avastin market share came down. This overall led to a slight PMPM increase within the category from 2023 to 2024. Anything else to note on this slide before we get to questions?
Sorry, Ben, I didn't come off mute there. One thing I did want to point out quickly was that similarly this year had a pause in production. So I'm assuming we'll probably notice that in next year's data. It'll be interesting to see if the shift moves more towards the Eylea biosimilars or somewhere else.
Yeah, I think that's a great point, Laura. So that right now is all of our content that we have prepared. So I think we can send it over to Kristen, who is going to moderate our Q&A. I'm sure we've gotten some good questions for the audience. So if you want to tee us up here.
We have some here, but if anything comes to mind, please type it in because we want to make sure that we're answering the questions you have. This is just a snippet of some of the data that you'll find in the trend report. There's a whole lot more there, but please ask questions here. So one of the first questions was with regard to regimen-based reviews. And I think, Laura, you had mentioned this in the survey section with regard to oncology. And the question was, are these also being implemented when components may cross the different benefits, both pharmacy and medical? So I don't know, Laura or Lisa.
Yeah. So, I mean, that is a really good question. And to be honest, we didn't go into that level of detail in the survey, but it would be something interesting to know. So I think maybe that's something we note to follow up, maybe even next year, because, we didn't ask the question. So at this point, we don't know, but I would like to find out for sure.
Yeah, and I guess I can speak in talking to some of the plans that use regimen reviews or that have implemented, they do look at oncology holistically. So they are looking across both pharmacy and medical. So good question, but certainly helps drive our survey questions for next year too, so that we can report on it. So thank you for whomever asked the question. All right, this next question, I think we've gotten all 15 years of our report, and the question is whether the data includes PMPM, if that includes the rebates. Ben, do you want to speak to that?
No, yeah, I can speak to that, but no, it doesn't include rebates. Like I said, the spend is the allowed PMPM, not the net. Same with the RX data that we have in the integrated section. That's total cost and not net cost. So rebates are not included.
All right, thank you. And then there is another question, also very good. Why did you select only a few classes for integrated data?
Yeah, I'll go ahead and take this one for the team here. So why we selected a few classes, we have 15 years of medical pharmacy expertise, and we really wanted to continue to emphasize our medical piece. But we do feel that having a holistic view of drug spend is important, and we know that clients are wanting this and health plans are wanting to see these type of views. So our report this year provided a sample of what can be produced with this aggregated data. And I know Laura mentioned we do like to take some things for a survey. So we may be asking when our survey comes out, what our reader reaction is to this type of information, because we want to ensure that anything we publish in the report is valuable information. So that's number one. And then as to the specific classes that we chose, I think Laura mentioned a few of it. We obviously picked oncology. It's the top spend therapy class for all lines of business. So we had to do oncology for you guys. MS, that has a good balance of provider administered and self administered injectables, along with oral medications that are available in both brand and generic. And so we thought it would be interesting to see how all of those different pieces tied in to create trend and spend. And then for IG, immune globulin, we thought that was interesting. On the commercial benefit, we saw that the vast majority of spend was on the medical benefit. But for Medicare, as Laura showed, the spend was more evenly split between pharmacy and medical. And that could potentially have to do with Part B as in boy versus D as in dog benefit determination as to where the drugs are on those benefit types. So just to give you a cornucopia of data that we hope you find valuable.
Yeah, and I think that's a really great point, Lisa, that looking at these therapeutic categories holistically, a drug is a drug, and looking at it doesn't matter which benefit that it falls under. So looking at it holistically helps to better drive strategies when you're looking at the overall spend. And we're also seeing a lot of drugs where there's crossover, where drugs are started on the medical benefit and then transition to self-administration and then are transitioned over to the pharmacy benefit. So as we see more and more of these approved, I think it's really going to help inform the data and help us understand why we're seeing some of these shifts and understanding where the lowest cost options are for members. So I think having those views, we're going to be expanding some of the categories and adding them to the overall report while continuing to report the medical data, because that's tremendously important to have line of sight on also. So I think all of that helps to inform strategies for health plans and any other stakeholders, quite frankly. All right, we do have another question with regard to, I know we mentioned it several times throughout the presentation, and this is with regard to some of the subcutaneous formulations of the oncology immunotherapies like Tecentriq and Opdivo, and if we're seeing any kind of uptake of these products in the 2025 data thus far.
Yeah. I can take that one because I'm probably a little closer to that data. So far, we really aren't seeing a significant uptake of those new formulations. I would like to caveat that by saying we only have a small portion of claims complete run out, since those products, a lot of them were recently, even Keytruda just a few weeks ago, approved. So we won't have any claims on those yet. So it's going to be interesting to see if there is an uptick. I'm sure our pharma friends are going to be out there pushing it eventually, and we'll just monitor it and keep track of this in future trend reports to let everybody know what we're seeing.
Okay, great. And then there is another question with regard to, and I think you mentioned this, Ben, but maybe we can go over that again with regard to the trend when you were talking about rare diseases, and the forecasted trend for 2025 was very significant in the Medicaid population. So do you want to talk through that for us, please?
Yeah, so we're anticipating some of the pipeline drugs in the rare disease category to hit the Medicaid population the most. But again, there's a wide range of likely outcomes. So if you're looking at any specific category or any specific drug, if it's approved, if we anticipated it being approved earlier in the year and it ends up getting approved later in the year, it may have half the impact. And so because of the delays and the way 2025 is looking so far, it's coming in less than we forecasted at time of publication, but it still seems to be substantial for Medicaid. And again, the Medicaid population is a lot more variable as well, depending on the mix of covered membership, depending on the states and their different coverage requirements and enrolled populations. So there's a lot of moving parts there. And so while you see our best estimate in the report, there is a wide range of likely outcomes depending on all those factors.
Yeah, so just to chime in there real quick, I don't know, for those who have read our previous report and watched our previous webinars, I think we had a similar blip on the radar with Gamifant. Wasn't that right, Ben? Like there was like an anomaly and it was being used, and all it takes is with these expensive therapies for one person to, for whatever reason, no longer use it, and you see these huge variabilities. So it is very difficult to predict.
Thanks, Laura. There's also a question with regard to some of the pipeline and the trends in oncology. Obviously, I mentioned in the beginning, those trends have been significant over the last 15 years, and then also even over the last 5 years at about 50% overall trend. Do one of you want to speak to what we're seeing in terms of the pipeline and the potential growth over the next few years in the area of oncology?
Yeah, I can take that. There's a couple reasons for this. One, and I know Kristen, we mentioned it when we talked about the AI kind of mammography readings, where number one is cancers are getting diagnosed earlier. We're having the technology, whether it be AI reading of mammography, whether it be earlier screening initiatives, where cancers are getting diagnosed earlier. So we're seeing the utilization potentially increase. And then that's factor number one. And then the second is drugs. And I know from our forecast, as I mentioned, the drug that was anticipated to have the biggest impact was Datroway or datopotamab, again, approved for both breast cancer and then got an approval for non-small cell lung cancer as well. The first approval was in January of this year. A lot of moving parts in oncology. We know precision medicine, where we're able to have therapies to target those specific genetic aberrations, if that's the right terminology, in those cancers. So a lot of different factors going into why we think the oncology spend is going to increase.
Well, hopefully, one thing that may trend that down a little bit would be the more recent move for some of these oncology agents that were only allowed to be previously administered in outpatient hospital because of side effects. Now there's some of that that's getting peeled back, and they may be able to move to other sites of service, given certain criteria. So that may help offset the trend a smidge anyway.
Great points. All right, well, we are winding up, but I see one more question, and I'm going to direct that to Ben about the category analysis and if that is inclusive of variable reimbursement rates. Ben, can you speak to that?
Yeah, so the allowed spend basically takes into account what is currently being reimbursed, absent rebates. So if the reimbursement rate is variable because of a rebate, then the rebate impact won't show up in the numbers, but the actual allowed cost on the claims is what shows up, which is going to be indicative of existing reimbursement rates.
Thanks, Ben. Yeah, so that takes into account if it's coming from a hospital outpatient, whatever the actual billed amount is included in the actual reimbursement rate. Yep. So that is put in there. And one additional question just came in our last few seconds here. I know we're at time. Curious if international sourcing is being looked at, especially for high-cost drugs. Lisa, you want to take that?
I don't have any line of sight into that. I don't know if anybody, like Laura, I know you work with the clients more closely than I do. I have not heard of any international sourcing, but
I think that comes with a lot of red tape and potential issues, especially with, I don't want to get political here, but there is a lot of sourcing of other products going on outside of the U.S. and additional tariffs. So I would think that, the additional tariff thing may waylay any thoughts of doing something like that. I don't know that there would be any savings involved.
Yeah, agreed. I think it's more to come. It's kind of a crystal ball right now to understand what's going to happen with all of that. But thank you all for all of your questions and attending today's webinar. I know it was an hour out of your day. I hope you find it informative. And again, here is the QR code to find all things Medical Pharmacy Trend Report and all 15 of our overall reports. So thank you very much for your time and have a wonderful afternoon. Bye-bye.